So thank you to our last panel for that really wonderful discussion. My name is Kayte Spector-Bagdady, and I'm a lawyer and a bioethicist in the Department of Obstetrics and Gynecology here at the University of Michigan Med School. Our next panel on law and policy is going to take many of the concepts that we've discussed today, from ethics to engagement to equity, and talk about methods of incentivizing that best practices are followed, or, at the very least, a baseline for ensuring protection for those that are most vulnerable. From prospective regulation to post hoc litigation to designing systems from the ground up, law and policy is where the rubber really hits the road for many of these complex normative goals. To help us think about these issues, we have with us today some of the most preeminent names working in this space. Our first speaker, Dr. Jerry Menikoff, with whom I had the pleasure of serving the Assistant Secretary of Health for a bit, is the Director of the Office of Human Research Protections, part of the U.S. Department of Health and Human Services. Prior to joining OHRP, he served as the Director of the NIH Office of Human Subjects Research, where he was responsible for day-to-day oversight of the NIH Intramural Human Research Protection Program. Immediately prior to coming to the federal government, he was Associate Professor of Law, Ethics, and Medicine at the University of Kansas. Our next speaker, Tania Simoncelli, is the Director of Science, Policy, and Advocacy at the Broad Institute of MIT and Harvard. Prior to her appointment at the Broad, Ms. Simoncelli served as Assistant Director for Forensic Science and Biomedical Innovation within the White House Office of Science and Technology Policy, and as Special Assistant to the Commissioner Margaret Hamburg and Senior Advisor in the Office of Medical Products and Tobacco at FDA. Last but not least, she's a former Science Advisor to the American Civil Liberties Union, where she spearheaded the ACLU's successful efforts to invalidate patents on the BRCA genes and end the practice of gene patenting in the United States. Our third speaker is Dr. Todd Rice, who is an Associate Professor of Medicine in the Division of Allergy, Pulmonary, and Critical Care Medicine at Vanderbilt University. There, he also serves as the Director of the Medical ICU. Dr. Rice uses the ICU as a learning healthcare environment and conducts comparative effectiveness trials. In addition to having his own NIH funding, Dr. Rice serves as the Vanderbilt PI for the Prevention and Early Treatment of Acute Lung Injury, or PEDAL network. The last person joining us for this discussion is Dr. Ray Hutchinson, who is the Associate Dean for Regulatory Affairs and Professor of Pediatrics and Communicable Diseases at the University of Michigan Medical School. He chairs the medical school's compliance committee and the conflict of interest committee and co-chairs the IRB Med leadership committee. Dr. Hutchinson also serves as a contact for investigators in solving problems related to research regulatory issues and interacts with federal and state agencies to enable the medical school to anticipate, influence, and plan for new research regulations. Thanks to you all, and Dr. Menikoff, the floor is yours.
I want to thank everybody for the invitation to come here. It's a great pleasure and privilege. I'm going to build, as was indicated, on the work of people up to now. Let's see. Wait. Do you move this forward? Will that keep it? Okay. So I'm going to be talking about a certain type of learning health system study. We've talked a lot about observational secondary use of data type studies. I'm going to be confining my discussion to interventional studies. So the assumption is we're going to be talking about a study in which you're actually going to do something to people. You're actually going to change the type of care they get. We've discussed already a number of the background issues here earlier on. Scott Kim talked about this stuff. Let's assume that the arms in the study we'll be talking about are within the standard of care. I want to fully acknowledge many of these studies may be minimal risk. It certainly can be minimal risk. I'm going to go through the initial slides here very quickly so we can get on to the other stuff. There's just some examples of how that could be. Some have claimed, Scott discussed this earlier on, that merely because all of the arms of a study are within the range of standard of care, that means that the study of necessity is going to always be minimal risk. He discussed that a bit and indicated that's wrong, and I fully agree with that, and I'm not going to say a lot about that. I'm sort of going to take that as a given. And I just want to highlight, in terms of our current regulations, that claim is also wrong. And I mean, this is a pretty straightforward thing when you just think about it. Different standards of care can have very, very different risks. If a person would have gotten standard of care A, and in the study you're going to move them to standard of care B, and those risks are different, and they're significantly different, let's assume there's a more than minimal risk difference, then you're imposing that more than minimal risk on the person by their being in the study. I mean, it's not that complicated an idea. Now, I will note, this is currently, you know, a core principle in our current ethical thinking and in our current regulations. I'm not saying you couldn't revise our ethical thinking and revise our regulations and come up with a more utilitarian approach in which it could work out that we would generate a lot more information more quickly, but there would be some losers. Some subjects in certain studies would be exposed to risks that under the current system they wouldn't be. So there'd be some winners or losers, but there could be a net gain. But basic point is, I want to talk about the system we currently have and how we understand those rules, as opposed to the dramatic change in ethical thinking that Ruth Vaden and Nancy Cass have proposed. And I just want to say a little more. You've already heard a bit about support, but I just want to drill into the details, because the major theme I want to talk about here, and basically in talks, I'm lucky if I can come up with one single idea, and hopefully I have at least one idea in this talk, is about needing to go into the facts of the specific studies we're talking about. So what was support? Involved a lot of babies, over 1,300 babies. They were randomized to low or high oxygen. They're very premature. Let's accept that all of the treatments they're randomized to were within the standard of care. And the core issue here is that there were concerns that at one end, the high oxygen end, there was a concern that you might be increasing the risk that the baby would get a condition called retinopathy of prematurity, which could cause blindness. And at the low oxygen end, the infant maybe isn't getting enough oxygen, and therefore that could lead to permanent brain injury or perhaps an increased risk of dying. So that's sort of a core part of the study. I just want to show you some very simplified, and they are simplified, but I just want you to get the gist of what this study meant in terms of actually changing what happened to infants. In quite a few of the centers where the study took place, and this is using information from the Duke consent form, the clinicians were trying to keep the infants in the middle of the oxygen range that was used in this study. So the oxygen range we're talking about is from 85% to 95%. So in those studies, in those centers before the study, they were trying to keep the infants close to 90%, smack dab in the middle, perhaps because, common sense, there were concerns about particular risks at the high end and particular risks at the low end. And maybe by being in the middle, you don't hit either of those perhaps greater risks. Not that we were sure about any of those, of course. So here's what they were trying to do in the study. They wanted a higher oxygen end and a lower oxygen end, and let's just put them together. So you went from, again, in certain centers where the starting point was the yellow range, they went from the yellow range to splitting the infants to the blue and red ranges. And that's what researchers often do. You want to get statistically significant results. You need your arms to have enough differences between the two of them. So they wanted to get them from the middle. They wanted to use the money effectively and move the infants toward the two ends of the continuum. And then I'll go back to this theme again, but ask yourself, if you were a parent, might you not want to know whether or not your infant was being enrolled in the study, and might you have good reason, based on the detailed information I'm telling you about the risks that the researchers are concerned about, to perhaps want to say yes or no to your infant being in this study. So, okay, so after the discussion about the support study, the office I run did release draft guidance, which spelled out exactly what I was talking to you about here. And you could find that guidance at that URL. And what's interesting, so here's the one idea I have about this. It was interesting how the discussion changed after the guidance came out, because before, the people who were saying this was always minimal risk, had a certain way of discussing this. And what was interesting afterwards is how much of the discussion since then has avoided discussing support-like scenarios. And I'll explain to you what I mean about this. Basically, I'm talking about dumbing things down and eliminating actually all the details that somebody might actually use in terms of wanting to make a decision. And they started discussing what was a very, very different type of scenario. So now I get to my unicorns. It's interesting, you know, Dr. Bosk was discussing mythical beasts, and coincidentally I'm discussing another mythical beast. We're not talking about the $1 billion companies from Silicon Valley, different type of unicorn. It's a far more exotic beast that we'll be talking about. Okay, so here's an editorial from the New England Journal, which was about the standard of care research, these, you know, issues that were generated by support and the follow-up. And it's interesting, I want to go through one of the scenarios that the New England Journal talked about. Again, this is after this draft guidance went out, and so here's a little bit of a quote from this. And so they're talking about a hypothetical study, and note, it's a hypothetical study. I'll say more about that, comparing treatment of mild persistent asthma with certain glucocorticoids. And notice what they say about their number of products on the market with substantial differences in price, but without substantial differences in efficacy or side effects. Notice they're not telling you much about possible differences between the two things that they want to study here. It's like they kind of sound the same. In fact, they've told you no difference other than, well, maybe there's some kind of difference, but we don't even have a clue what it might be. Here's another quote, and this is from you know, one of the studies that David Magnus was telling you about earlier. And this is what they were actually telling the people when they were busy giving them these surveys that we talked about. And notice it's talking about treating hypertension. And it's telling it is drug A and drug B. And look at the final bullet here. Drug A and B both cause mild side effects that are similar in frequency. And the first bullet, data are lacking in the relative effectiveness. Not actually telling you a lot of information. Let's say somebody asked you, well, do you care about getting drug A or drug B? They've thus far given you zero information you could use to figure out why you would pick A versus B, other than we're not sure which of them is better. This is, you saw a bit of this because David presented this. This was from the little, you know, video that they used to educate the people who they then ask questions to get their study results about what it means to do these sorts of comparative effectiveness studies. And I'm going to blow up the large item on the bottom there. So here's what they're telling you in terms of thinking about this is a study which involved a choice between drug A and drug B and drug C. And notice drug A is good, drug B is good, drug C is good, and we have these three very, very smiling doctors there. And by the way, this study was called ROMP. I mean, I would imagine these people doing your little happy dance, and we talked about kind of singing earlier. Maybe you're channeling a little, I can't sing, Pharrell Williams here. You know, we're all happy and everything. And you might think about that if this was a study that was coming from a pharmaceutical company, whether how much you'd think about this being a really, really good study, as opposed to garbage in, garbage out, but instead it's a study coming from leaders in the bioethics community. But basically notice, they're giving you zero information to pick among drug A and drug B and drug C. And had you been told this, is there any reason you wouldn't want to be in this study? You get one of these great drugs and you have these smiling doctors and you don't have a clue as to which of these drugs you might want to pick. So basically this is sort of summing it up. Instead of, you know, starting out with studies where you had specific risks that you're talking about, we now seem to be having a conversation, particularly to people who are pushing it back on the issues raised about support. They're sort of saying, you know, let's think about these studies where we actually don't have anything specific to worry about. Let's think about studies where we have no pre-existing information to pick among one or the other. And so I have two questions relating to this. First of all, is this a sort of research we should do? Namely, should we be focusing on these studies where we have no reason to actually suspect specific differences between two drugs, but we say, well, there are two drugs that treat this particular condition, having a clue which of them is better, you know, even though we presumably their standard of care have been using them a lot and not a single bit of evidence has shown up to suggest a difference. Is that the sort of study we really want to conduct? And secondly, let's look at the real world. Is this a study that people are actually doing? Maybe that actually tells us whether or not this is a good or a bad thing to be doing. So on the first question, what sort of research should we be prioritizing in a world of limited resources? Should we be prioritizing research where there's no evidence suggesting specific differences, as opposed to treatments where we already suspect specific differences, but we're not sure, and therefore let's drill into that to see whether these differences actually are real. Anybody know who this is? I seem very unlikely to know this. Willie Sutton, you know, you asked him, why do I rob banks? Because that's where the money is. I mean, if you're going to start looking at data and you're looking for differences between different types of treatments, you might actually want to look at the types of treatments where we already have, you know, a presupposition that there might be differences. I once spoke to Rob Califf in his pre-FDA days, and he said, yeah, I would think, you know, if you want to do research, look at where you think, you know, you're going to actually get good results because you think there are already differences. So now let's go on to the second part of this. What kind of research are we now doing? Are we doing a lot of no suspected differences research? And again, because a lot of people keep coming up with these theoretical examples. Let's compare these two drugs. We haven't a clue about a difference between them. And let me just give you some examples, because these are examples, you know, many of us deal with day to day in terms of people raising them. There was the support study. Again, very real suspected differences there. Information that somebody might actually want to use in terms of picking one or the other as opposed to being in a trial. Other examples, patients with Wegener's granulomatosis. Do you want to have a taper of your steroids, which may mean your disease, which could perhaps kill you, would be exacerbated versus instead staying on the steroids and increased risk from being on the steroids. Third bullet here is the adaptable study that PCORI is funding, higher or low doses of aspirin for preventing cardiovascular disease. We know a great deal about what higher or lower doses of aspirin might do to you. First bullet here, frequency of CT scans. They discover you have a lung nodule, something in your lungs that they picked up on a CT scan. And maybe a 5% chance that's cancer. But there's a dispute about how you don't want to biopsy these because that's a big deal. So instead you follow it with CT scans. And there's uncertainty about how often you should do the CT scans. Do you want to do them once, you know, every year, or do you want to wait for 2 years? Now, it'll be fascinating to ask people. Some people might be more concerned. I'm more willing to risk a new type of cancer being generated by too much radiation as opposed to not picking up that this thing actually starts growing, and that because I already have this thing in my lung. So this gets back to, wouldn't people perhaps have notions of their own preference for one of these? And there's a hypertension study is one of the examples. Some of the other, the New England Journal study and yeah, ROMP was indicating. And there's a real study, and you could see real differences in that. So going back to, let me sort of end on this, going back to the support study, again, a lot of these studies have real information based on which people might actually have preferences, the way we normally make decisions. And again, most of the real studies out there that people are discussing are studies in which this is the actual scenario. It's not this hypothetical unicorn-like study where we haven't a clue which of these drugs is better in terms of efficacy. We haven't a clue in terms of the possible differences. When people actually spend millions of dollars to do these studies, they're generally looking at things where we actually suspect differences. And when we suspect those differences, often normal human beings, in terms of thinking of being in that study, might actually have a preference. And in terms of sort of encouraging, giving a suggestion in terms of future research, if we want to do future questionnaires and these sorts of ROMP-like studies, I would think, why don't we do a version of this, but instead of having these doctors, A is good, B is good, C is good, I'd love to see a study. I mean, I don't know the results of this, but let's think about doing it. Well, here's C is there's a possible risk will increase the risk that your baby goes blind. On the other end, on the low oxygen end, there's a possibility will increase your risk that your baby dies or develops permanent brain damage. Or there's we could have your baby in the middle here. And these are all options, and are you willing to kind of have your baby randomized to one of these two as opposed to kind of perhaps picking to stay in the middle? I think that would be a fascinating study to do, and that might tell us more as opposed to why in the current ROM questionnaire we actually get the surprising result that these people actually don't care about randomization any more than they care about secondary use of the data. So I'll end at that, I think. Thank you.
Thank you. I want to say thanks to Kate and Jody for inviting me to talk. This has been a really great day already. I'm looking forward to the rest of the afternoon. So I wanted to talk a little bit about how am I advancing these? Just with the clicker? Okay. About an emerging model for direct-to-patient engagement in research that we are piloting right now at the Broad Institute. And then I'll say a few words about some of the ethical and legal and policy challenges that we're really sort of butting up against and grappling with right now. And thankfully, I'm happy to hear that lots of us are thinking about the same things. What am I doing? There we go. Nope. How do I advance? Oh, this thing. This thing? See, it's not just me.
Oh, there we go. I think you have to a little bit down. It's because this thing's pulled out.
So I have to,
I think it will work
is that
now.
forward and back?
Yep.
Okay.
There you go. Sorry.
It's okay. So since the completion of the Human Genome Project, we've seen quite a bit of progress, I think it's fair to say, in unpacking the genomic drivers of cancer. Some of these advances have led to some pretty incredible advances, including a growing list of highly effective drugs that are tailored to particular molecular characteristics of a given tumor. But if the end goal is to be able to interpret every patient's genome, cancer genome, and to use this information to identify optimal treatments and anticipate and preempt resistance, we're still a long way off from being able to get there. And to get there, we at the Broad believe that one of the important elements is that we need detailed molecular and genomic characterizations of tens, if not hundreds of thousands of tumor and germline samples along with medical information. We need to be able to learn directly from the experiences of cancer patients. It's not sufficient just to have tumors or just to have germline sequences. We need to be able to integrate this data. So unfortunately, while patients and cancer patients especially are more willing than ever to participate in research, there are really few opportunities for them to do so, and this gets to our institutional challenges. So for example, only 5% of cancer patients right now participate in clinical trials, and 85% of cancer patients approximately are being treated in community settings. So rather than large academic cancer centers where they may be offered opportunities to participate in research. As a result, their tumor samples collected in the course of their care are basically sitting in local pathology departments and largely going to waste, if you will. So most patients are not being offered opportunities to participate in research. Most tumor samples are not readily available for study, and we're failing to systematically learn directly from the experiences of patients. So a little over a year ago, Nick Wogley, who's a medical oncologist at the Dana-Farber and an investigator at the Broad Institute, launched a pilot project that sought to address this challenge by engaging patients directly in research through social media and utilizing social media and other online tools. So his theory was that today there are a lot of patients, many patients are internet savvy. Many of them are connected to other patients and patient organizations via social media. So could we leverage those tools to recruit and engage patients in research? And could it actually help to democratize research, at least in the sense of giving patients opportunities to participate regardless of where they live or are being treated? So can it help us to get at that 85% of patients who are treated in community settings? So this is the website for the Metastatic Breast Cancer Project. When you go to the site, it says, do you want to help transform our understanding of metastatic breast cancer? You click Count Me In, and that brings you to a basic survey that was actually designed in consultation with many patients over the course of some months. It's a list of 16 questions that patients answer in, on average, 6 minutes. It asks some really basic information about their demographics and when they were diagnosed with metastatic breast cancer, what drugs they've taken, et cetera, et cetera. If they've had any extraordinary responses, how long they've been living with cancer, et cetera, et cetera. They send that online survey back, and the next thing that they receive is an online consent form. The consent is really very broad. It's pretty similar to what we heard earlier this morning with the Mayo Clinic Biobank. It asks participants for permission to collect a saliva sample, obtain stored tissue samples if they have them, and perform genetic testing, both germline testing and tumor sequencing. It also requests them for copies of their medical records and for permission to link those records with their genetic testing results. And patients also consent to the use of their data in future research studies, including studies that are not in cancer, and to share their data with public databases. Those patients that consent are then sent a saliva kit and asked to mail back their saliva sample, and their medical records are obtained by the metastatic breast cancer project team and centrally reviewed and abstracted. Tissue blocks are requested from the local pathology departments by the team, and then we get into the genomic analysis and interpretation. So we were really kind of blown away because when we launched this project, we didn't really know what to expect, to be honest, but we were really surprised to see an incredible response. And it's been just about a year now, and over 2,900 women and men with metastatic breast cancer from all 50 states have joined the MBC project. There are also some really interesting things with just the basic online survey data. Has already helped us identify some really interesting subpopulations to study. So, for example, there were a surprising number of individuals who had been living with metastatic breast cancer for more than 10 years. So it'd be interesting to know why have they done well. We've already identified a couple of drugs that have popped up in terms of medicines that people seem to be having, at least some subsets of individuals seem to be having an extraordinary response to. And there's some other interesting issues. But just from like very basic patient reported data, it's starting to help to drive some interesting hypotheses that we can then go on to test. This effort has been really a collaboration. We started out just working with a couple of different patient advocacy groups, and that has grown over the past year, and there are now 20 organizations that are affiliated with the project. We've engaged patients and advocacy groups from the very beginning in conceiving and designing and implementing and testing and refining the project, including, like I said, the initial survey. And it's really kind of amazing that one of the other striking things is that we've been tracking how patients sign up. And it's really word of mouth that is bringing in most of the patients. We do not advertise for this project beyond the initial Facebook page and the initial online media sort of work, but we're not doing any advertising. Most of this has actually been by word of mouth, by the patients themselves that are actually bringing people to the website and talking about the project online and on Facebook chats and things like that and Twitter. So these are just some examples of some of the really great responses we've gotten from the patients. I want to live and watch my children grow up, but if I can't, then I want to leave a legacy and a cure. As someone who does not live near a research center and therefore cannot easily participate in trials, I finally feel like I can contribute. Amazing how happy that little box makes you feel. That's the box that they return their saliva kit. I feel like a 2-year-old. Let me help. I feel a sense of pride and belonging because of this. Give us hope for the future, and if not for some of us, for our families. So there's really been just an incredibly powerful and overwhelmingly positive response from the patient community. All that said, there are definitely challenges with doing this kind of direct-to-patient project, and especially when we think about developing out additional pilots and scaling this effort. What if we wanted to do this for all cancer patients? There would be lots of challenges with that. First of all, coming up with the funds to sequence all cancer patients. But aside from that, there are a lot of issues with scale. I'm going to talk about the last two in particular, but obviously governance is and relatedly building and maintaining patient trust are huge and things that we have been grappling with all along. I think one of the really great things about the MBC project is that there was a huge effort to communicate. There have been not just online things either. We've done a lot of in-person things, bringing groups of patients together to talk to them and creating different forum for people to come together in person as well as online. And it's sort of one thing to do it with one particular community, but as this thing has grown, and even now that we're 3,000 people, I'm starting to have my own concerns, like are we outpacing ourselves, and can we maintain that enthusiasm, that trust as we grow? And then let me talk a little bit about what I think is one of the biggest challenges with this effort, which is collecting and abstracting medical records, which, as many of you probably know, is a painstakingly difficult and laborious task. Despite the major federal push under this administration to digitize our health records, we are still dealing with paper. When it comes to research, we are still receiving these medical records via fax, predominantly. Sometimes a PDF, a scanned PDF, that we end up having to print out and then manually abstract the record, the various elements of the record that we're interested in for research purposes. So why is this the situation we're in? I think a lot of the people in this audience are probably aware of some of the history, but Congress passed the HITECH Act in 2010, which included a $30 billion incentive payment program to offset the costs of going digital, and we doled out subsidies to providers between 2010 and 2014. And this was very successful in some ways. By 2014, more than 70% of hospitals and doctors' offices had adopted EHR systems. That was up from 17% in 2008. But the resulting system failed to deliver on the promise of these systems to enable interoperability, which was one of the stated goals of creating this system. Part of this was a failure by design. So these systems were primarily designed to optimize billing rather than to facilitate data sharing. They were designed primarily in the interests of, not really in the interests of doctors and patients. And there were also some perverse incentives on the part of EHR vendors where there wasn't really an interest to build in, say, an export button into these systems because, of course, that would be a way for providers to then easily switch to another vendor if they wanted to. If it was easy to export the data, it would be easy to switch. And this is partly what this article is talking about, that there's an incentive to lock in customers by making it difficult for them to switch to competing vendors. So sort of to exacerbate this problem, there's also been sort of increasing market consolidation, which also impacts incentives for change. So Epic and Cerner today have come to dominate the market, for example, for large hospitals, and I think this is now a little bit outdated. I think now some people have predicted that Epic will have a virtual monopoly in terms of large hospital systems in the next, say, 5 years. So what are the solutions? What are the policy levers that we can pull to try to fix this problem? There are really sort of two approaches that people have been working on. The first really emphasizes interoperability. And that's basically CMS, the incentive payments program, the meaningful use program that probably most of you know about, that basically creates incentive payments to providers that adopt certified electronic health records and achieve meaningful use. And as part of that, the ONC, the Office of the National Coordinator for Health IT, specifies the capabilities and functions that EHRs must perform in order to be certified. And so this has been a there have been various iterations of meaningful use and trying to sort of ratchet in these systems to try to get them to make more of their data easily accessible and interoperable across systems and to be able to move data more easily. Unfortunately, the process has been pretty slow. And the real limitation, especially from a research context, is that it enables access and sharing of a very limited set of data right now. And that's basically this, what's called the CCDS, or the Common Clinical Data Set, which is actually just a subset of about 21 elements of a medical record. The second approach, and this is one that organizations like Get My Health Data have started to talk about, it's really about making consumers more aware that they have a fundamental right to their complete medical record under HIPAA, the HIPAA privacy rule. The language is actually quite broad. You have a right to access and obtain PHI in a so-called designated record set, which includes any information used in whole or in part by or for the covered entity to make decisions about individuals, and it must be provided in an electronic form and format requested by the individual if readily producible. If readily producible is an important caveat, though. So when we compare these approaches on meaningful use, you can get standardized machine-readable data, but it's limited. And so from a research perspective, that data may be insufficient for patients, even monitoring their own health. But it's definitely insufficient for many research initiatives. It's not sufficient for what we're trying to do in cancer research. On the other side, you can leverage HIPAA right of access and patients could help drive, potentially, the liberation of their own data and could donate it for research purposes if they wish to. But then we're going to be dealing with totally unstructured data and have to deal with cleaning the data on the back end. So I've been thinking a lot about what is the delta between this CCDS that's in structured format and the DRS. Can we start as a research community thinking about, for the sake of developing learning health systems, what are the other elements of the healthcare of the health record that we want to see standardized and more readily shareable? And also, if it were really easy for patients to make HIPAA right of requests, could we leverage that to help create more demand for liberating medical record data for research? I'll skip this for the sake of time. Do I have one more minute just to talk about return of results? Okay. So the other thing I want to talk a little bit about is return of results. Return of results can be thought of as many things along a continuum. There's public release of data. There's return of general study results to patients. Those are things I think the NBC project and Count Me In initiative at the Broad are already embracing and prepared to do. And then there's return of individual results to patients and the return of incidental findings. And those are much trickier from a regulatory perspective. So CLIA, the Clinical Laboratory Improvement Amendments in 1988, they set quality standards for laboratory performing clinical testing. And research laboratories are generally exempt from CLIA so long as they do not report patient-specific results for the diagnosis, prevention, or treatment of any disease or impairment or the assessment of the health of the individual patients. CMS has interpreted this fairly strictly and has concluded that any return of results would violate this exemption, including a situation where patients are counseled. So they're given their results, but they're counseled that the results are not for treatment purposes, and they should seek additional testing at a CLIA-certified lab. So some have taken issue with this. SACHARP, the Secretary's Advisory Committee on Human Research Protections, has actually challenged this and has been pushing CMS to revisit this and has said, if you're not returning the results for treatment purposes, that's not in violation of the regulations. I don't think CMS is going to necessarily budge on this. There's a big sort of debate about this issue in HHS and across the government. CMS could, in theory, exercise enforcement discretion and allow research labs to refer participants to follow-on testing. Researchers could just start conducting all testing in CLIA-certified laboratories, but that would be very, very expensive. And another way we could maybe sort of move this along is that researchers could build in two-step testing into their protocol where individuals consent up front to have testing repeated in a CLIA-certified lab in the event that the research reveals potentially actionable results. I actually don't know where I fall. I don't have a strong I think there are ethics on both sides of this debate. I think it's a really important issue. Right now, we are conducting our testing in a research laboratory. And we have had a few requests, though, from patients asking if we could return data. When we explained to them the regulatory that we can't by law, they're okay with that. But we are seeing an increasing number of patients ask for that, and people starting to think that this is part of the quid pro quo of participating in research, and that we should be thinking about returning more to individuals. So I will end up with that, but look forward to the discussion. Thank you.
Good afternoon, and thank you for making it all the way to the end. Thanks for inviting me, Katie and Jody, and others from the Institute. I come hopefully trying to tell a little bit of a different story. I was asked to try and tell a little bit of a different story. I am the medical director of Vanderbilt's IRB, and that's one hat I wear. But the other hat that I actually wear is as a physician scientist in the ICU. I'm an intensivist that takes care of patients and conducts clinical research in the ICU. And in the last 5 years, we have very much moved into this using the ICU, which at our institution is a closed environment, as a learning healthcare system and trying to learn from the care that we provide in the ICU. And so what I want to do is try and walk you through the development of this program and what we've kind of done with this program. I do not have any financial disclosures. The one disclosure that I would tell you is maybe an intellectual disclosure. Anybody who is doing my presentation after Dr. Menikoff did his presentation, you may want to wonder about the intelligence of. People have not claimed that I'm the smartest guy in the world. You may think that when we get through with this, but we'll see how this goes. So here's what I'm going to do. I will describe how Vanderbilt has transitioned QI projects in the ICU to our learning healthcare environment. And I'll specifically walk you through 3 studies that have either been completed or are almost done that we have done this for. And then I will talk about some obstacles that we've sort of encountered and gotten around along the way. So the first is chlorhexidine bathing in the ICU. And the story of this really was the beginning of our learning healthcare system. And the story is that at the time, my mentor was the director of the medical ICU. He was a fairly powerful figure in all of our ICUs. And administration came to him and said, we are changing, so all the ICUs have to do chlorhexidine bathing. He was a little bit stubborn in his ways and wasn't a believer in chlorhexidine bathing. And so he pushed back a little bit and he said, why don't we actually study it before we just implement it system-wide in our ICUs? And maybe somewhat surprisingly, the administration said, okay, if you can study it, let's study it. So here's the background. Healthcare-associated infections are the most frequent complication of our patients. They increase morbidity, mortality, and chlorhexidine is actually a broad-spectrum topical antimicrobial that's used to prevent infections. It's used in a number of different ways. They actually put it on bathing cloths to bathe patients in the hospital or in the ICU. And there are multiple studies, none of them of very high quality, that suggested that these may reduce these hospital-acquired infections. There was one large randomized trial that was not actually out when we started our study, but came out in the middle of our study, which made us reassess whether we should continue our study, which said, again, that these reduced the acquisition of infections in patients in the hospital and in the ICU. But when we started, we had the hypothesis that this would work. These chlorhexidine bathing cloths would actually reduce infections. But we needed to figure out a way to study this. And as it is, it turns out that it may not be bathing you that prevents your infection. It may be bathing your patient next to you or the other patient that the nurse has. And so we were pretty confident that we couldn't do this in an individual randomized way because that wasn't even necessarily how the mechanism worked. So we set up what was called a cluster randomized multiple crossover trial, and I'll show you the actual diagram of this on the next slide. All 5 of our ICUs, our adult ICUs, actually participated in this for a year time period. And pretty much everybody that came into the ICU was included. We excluded non-adults, so every once in a while we'll get a child in our ICU. We just didn't collect data on them. They still ended up getting bathed with whatever cloth was available, but we didn't collect data. And we have a burn ICU as a 6th ICU that we didn't use our burn ICU because they obviously do different skin care than the other ICUs. The IRB approved this with a waiver of consent, so we got an approval from our IRB. All patients are bathed daily with either a cloth impregnated with chlorhexidine or a very similar cloth without chlorhexidine. Both are commercially available. And it turns out that when we started the study, 2 of our 5 ICUs used chlorhexidine and 3 of our ICUs used the non-chlorhexidine impregnated cloths. We didn't change anything else. And fortunately for us, all of our outcomes, which were hospital-acquired infections, our hospital has to collect and federally report anyway. And so all of the outcomes were already being collected by our hospitals in a manner that we could use as the outcomes from our study. This study was conducted by one of our fellows without a research coordinator because of the fact that all of those data were collected. Here's what the actual schema looks like, and I don't have a laser pointer, but if you follow one of these, each of these 5 columns is an ICU, and they're randomized to either the control, which is the non-chlorhexidine impregnated cloths, or the chlorhexidine impregnated cloths. And they alternate over the course of time. There's a washout period between these where everybody used non-chlorhexidine wash cloths. And it ended up that in the year, we ended up with just under 9,500 patients that we included in this study because of the fact that everybody that was admitted to our ICU was enrolled in this study. This turned into a big JAMA article that we presented at national conferences. This is 3 years, 2 years later, I guess. We still get questions about how did your IRB give you waiver of consent for this, which was interesting to us because for us, there was never any question about waiver of consent because as I said at the beginning, right, it's not even necessarily the patient. It may be the patient's neighbor that's the one that's influencing their outcomes. So this one for us we thought was pretty easy, although we still do get lots of questions. And it turned out that chlorhexidine actually didn't lower our infection rates at all, and we are not using them at our hospital now because of the results of this study. The second one is the one that's not quite done yet. This is called SMART, and it uses 2 different IV fluids that are routinely used in the care of patients. And it turns out, if any of you are physicians, surgeons and medicine physicians argue about what the right fluid is. We've had these fluids for about 150 years. Nobody's ever actually done a great study that has said which one of these is right. And we're both right. Maybe there's a different fluid that's right for different patients, but we don't know that. So this is set up the same way. Our goal is to enroll a lot of patients, deliver the intervention in a time-sensitive manner, and I'll talk about that in a minute, and then collect the data. If we did it with a traditional approach, individual randomization of patients, it would take us about half a decade, millions of dollars, and a long time to do. But with this approach that we were able to do, we can do it in a faster time period. So we use the same cluster. And the reason that we're doing this is because in the ICU, there are many times that I'll go see a patient and want to give that patient fluids for low blood pressure, for example, and never ever write an order. And I'll tell the nurse, just give them some fluids. And given that as our background, we worked with our pharmacy to only provide the study fluid to that ICU for that month. So that when the nurse went to what we call the Pyxis, which is the drug dispensing unit, they couldn't grab the wrong fluid. There was only one fluid there for them to grab. Now, on top of that, we recognize that there are some patients where that fluid may not be right. And in those situations, the doctor can actually opt out of this fluid and order the other fluid through our health system, through our electronic order system. So here's the delivery that's what our Pyxis looks like. Here's the delivery of the fluid to the Pyxis, and it alternates by month. And again, all 5 of our ICUs are participating. This is what our pop-up says. If you are in a month that is fluid A and you order fluid A, you never see a pop-up. If you're in a month that's fluid A and you order fluid B, you actually would a pop-up that says this patient is in this trial. You can still get fluid B. They're supposed to get fluid A for this month. You can still get fluid B if one of these criteria is met. And there are 2 specific criteria, and then the third criteria is my doctor says it's right for me. and so the physician preference. We actually piloted this and know that in about 96% of the time, the doctors are okay with whatever fluid your study fluid is, but about 4% of the time, the doctor will actually override it and say, give me the other fluid because I think that fluid is the right fluid. This study is also done without a study coordinator because all of the data that we're taking, we electronically extract in a real-time basis from our electronic medical record, and it gets dumped into our data system. And we've worked with our bioinformatics people to electronically abstract in-hospital death, new renal replacement therapy, which is a fancy way of saying dialysis, and then if your renal function is essentially half of what it was when you came in, when you leave the hospital, we collect that also. Here's the pilot that's also now published. But the big study, which will enroll 15,000 ICU patients, will finish in April, I think, is the end date. So those were all done on a unit basis with a cluster randomization. But let me give you an example of an individual patient randomization study that we've done. So in the ICU, when you have problems breathing, you get put on a breathing tube. And putting that breathing tube in is something that we do at the bedside in the ICU. There are two main devices to do it. One is a device that allows you to directly look at the airway, and the other is a device that actually puts the airway on a screen. And at least in the operating room, there are some data that say putting the airway on a screen and trying to place that tube gives you a better view and may improve the ability to put that tube in a shorter time period. But this has never, ever been tested, actually, in the intensive care unit. So we did this in the intensive care unit in this open-label randomized trial of these two. We included anybody that was being intubated in our ICUs, and we excluded anybody who didn't meet our criteria, but also anybody, again, who the doctor said, I know one of these devices is better in my patient than the other one. And it turned out that happened about 10% of the time in these studies. We confirmed what they found in the operating room, which was that the video scope actually gives you a better view. But interestingly, our primary outcome was not the view, the ability to pass that tube. And it turned out that even though you had a better view, you weren't able to pass the tube any better. And we also collected time to get that tube in, and it turns out there was no difference in the amount of time either. So neither of these devices was superior to the other in actually successfully doing the procedure. This is also published. All of these done with a waiver of consent. And you say, well, that last one is individual randomization. How did you get a waiver of consent for that? Well, we presented to our IRB two things. One was that the use of a video scope versus a direct scope were what we called arbitrarily, some people like to call it haphazardly done in practice anyway, and about 50% of the time somebody used one or the other. There was an opt-out where if the physician thought they knew what the right one was and wanted to use the right one, they wouldn't put their patient in the study. And then the third part, which probably carried the day, was we did not get written consent for this procedure in over 90% of the time that we do it anyway, because we just don't have time and the patient's just not aware enough or understanding enough for us to get written consent. So to get written consent for the research part would have been really hard when we don't even get it for the procedure 90+% of the time. So these are the challenges that we overcame. We talked about informed consent and waiver of informed consent. And whether or not these studies are truly minimal risk is still largely debated. These are critically ill patients. Some of them, the chlorhexidine bathing, the infections, you could argue, may not be an outcome that people care about. The fluids, actually, the outcome is death and renal dysfunction, which I think our patients probably do care about. The designs are both cluster and individual randomized designs, and I showed you both of those. Delivery of the intervention has been controlled, both in the supply to the ICUs for the fluids and the bathing cloths, and then in the intubation, both devices are available in the ICU, and it's just which one you grab. And then collecting outcomes. For the chlorhexidine bathing, we got lucky because our hospital had to collect those outcomes and report them anyway, so we didn't have to do anything other than partner with the people that had them. The IV fluids, we've partnered with the bioinformatics people so they can collect them electronically. And then in the intubation study, the randomization is actually done by an envelope, sitting an 8x11 manila envelope sitting in our ICU. And when you open it, one side has what group you're randomized in. The other side has this, which is the data collection form. And somebody who's present for the procedure, usually our charge nurse in the ICU, records the data while this procedure is being done, puts this sheet back in the envelope. throws it back in the workroom, and we pick it up. So again, the data are collected in real time without a nurse or anybody having to do anything outside of that. So we have started using our ICU as an environment for a learning healthcare system, and we've tried to navigate some of the obstacles and the difficulties in doing that. Some of those include waiver of consent, study design, collection of data, and then specific outcomes. But in order to do this, we've had to work with pretty much every aspect of our healthcare environment, including nursing, our pharmacy, our bioinformatics people, and obviously our IRB and ethics regulatory people. Thank you.
Yeah, so please feel free to stand up at our microphones to ask any questions you might have. While people do so, I think I know they roll, sorry, just for fun. I think I might ask the first one. And I thought that this was a really great combination of presentations, sort of going over law as well as policy and then into practice. And so I guess my first question is something that I always struggle in this space, is what is appropriate for regulation? What is most appropriate for institutional policy? And then what is most appropriate to leave up to individual practice? And if you either had an example or sort of a framework about how you think about this in your daily jobs, that would be wonderful.
Well, I guess the issue that comes forward to me as I hear these talks, and I am a regulatory person here at the U of M Med School, relates to not so much to the interventional trials that Dr. Menikoff talked about, but the use of data and how we can, obviously protect the subjects and their data, but protect our investigators as well, so that they have a well-conceived structure in which to do that work. Now, Dr. Rice has found a nice pathway forward in terms of doing his work, but he's also pretty well informed in terms of human subject regulations. And I think there probably are many situations in our health systems where, similar work may go forward with not quite the same rigor that you've incorporated in your projects. And I'm just a bit concerned about, and I think maybe that's where, I don't know if it's regulations or guidance could help us a lot. Particularly, as these like quality improvement / research projects become bigger and bigger. We deal with a lot of Blue Cross Blue Shield quality initiatives that span multiple hospitals across the state of Michigan. They start off as quality improvement projects, and then something's discovered, and it seems to drift into the research arena, just by virtue of the fact that you're collecting data from multiple sources, trying to create systematic knowledge. Begins to blend together, and I think that's one area in which we need some help. Again, might be guidance rather than regulation, but I think that's a dilemma for me as I hear these discussions today.
So I think there's some truth to the fact that me having some knowledge of the research regulatory work in this country has very much helped us design studies that have been palatable for our IRB in our environment. And although it's very, very nuanced, people don't understand what having an out for the doctor thinks they know what's right, so they don't have to put the patient in the study, does in alleviating an IRB's concern that you're forcing a doctor to do something they don't think they want to do. It turns out that with the interventions that we've chosen to study, it doesn't come into play very much. It turns out that most of the physicians and most of the patients don't have a strong belief that they know what is right for their patient, and they're willing for that patient to go in, but they always have that out if they need one. The other thing that I would say is that the use of cluster in our trials has become not necessarily an epidemic, but something that people have viewed as a means of avoiding consent. And we've struggled with this a lot. I don't know the number of times I've told an investigator to do a cluster randomized trial. The reason you're doing it should be because the science makes that trial use a cluster design, like the infection questions, not because you're trying to use the cluster to avoid having to consent patients. But that is very much lost on a lot of people, and they think, oh, if I do a cluster randomized trial, right, I don't have to consent because it's a whole group, and therefore it's not practicable to consent, and I'll just do it that way. And at least at our institution, we've put our foot on the ground and said that's not the reason to do a cluster randomized trial, and you won't get out of getting consent just because you came up with that design.
Thank you. Yeah, Dr. Nathan.
Yeah, Charlie Koopman, emeritus professor here at Michigan. I have a problem with the Vanderbilt approach because as a patient, I want to know if I'm going to be in any study whatsoever. And I want to have the option to opt out. So I would think that if I were going to Vanderbilt and knew I was going to be in that, one of the first things I would do is sign something that says I will not be in any research project without my knowledge and consent. How, are you able then to say, well, tough luck, because we've got institutional approval to put you in the cluster? Because I don't think that's right. I think every patient has a right to say yes or no to any potential research study.
Yeah, so the answer to that depends a little bit on the study. And let me give you a couple examples. So Vanderbilt has, when you walk in the door, a form that you'll sign that says, this is a teaching hospital, research is done here, we study our environment in order to make it better. It's a consent form that the legal group and I argue a lot about because I don't think it's an actual informed consent. They, because of some of our arguments, have excluded that consent for any patient that comes through the emergency department, for example, because obviously I have a bias. I work in an ICU. My patients come in extremis all the time. They'll sign absolutely anything I put in front of them. They just want to feel better. And so, we've tried to be thoughtful in how we allow people in with those. If you don't want your medical record looked at from a research standpoint, the only opt-out is to not come to Vanderbilt. If there are other research things, like, for example, many of you know we do BioView, which is actually a DNA database of leftover blood from blood samples. And if you don't want that involved, there's an actual means that's set up, a formal means where you can essentially, now it's actually an opt-in. You have to sign a sheet to opt in. It used to be an opt-out. But that's a mechanism that we have that you can opt out. So it just depends a little bit on the study. But I think there are a number of people who feel the same way in my institution, even in administration in my institution, and have struggled with how do we effectively inform people that this is what's occurring here, and therefore give them a means to either not come here if they don't want that or opt out of it if they can.
But I'm specifically talking about something like the intervention with the endoscopy. I personally know which I'd want, and therefore I would want to be able to say what I wanted, not what you want when you pull a piece of paper out. So what I would want.
Yeah.
That's
Yeah, the only in that study, the only out is that your doctor would opt you out. So I guess if you had conveyed to your doctor you knew what you wanted, they could have opted you out. But it doesn't happen very often where somebody walks in, they're not in the throes of doing the procedure and says, oh, by the way, if I get to the point where I need this procedure, I want device A or I want device B, right? That just doesn't happen very often. So yeah, and they're certainly on the fringe of the regulations and what people think. And you've heard it here all day, right? There are people who say, absolutely, this is what happens in care. And if you came in and we weren't doing the study, you wouldn't pick which device you wanted either, because you wouldn't have talked about it with your doctor, and once you got to that point, your doctor picked one. And there are others that say, yeah, but I want my doctor to do that, right, and not an envelope with a piece of paper.
Yeah, please.
So thanks to a great panel. Two corrections or objections to your talk, Jerry. First, just want to be that we're very clear about the difference between an interpretation of the regulations and what the regulations actually say. And I worry there might have been a little confusion about that, since whether or not, for example, support violated the actual regulations is a matter of interpretation. A lot of very knowledgeable people with expertise on the research regulations disagreed that it did, and in fact, currently the OHRP's standing findings are that there were no regulatory problems with the support trial, since the initial findings were put on hold or rescinded. And the same thing, I would say the same thing about the guidance document, which has not been finalized, that were put forth. But then maybe more substantively, I think part of the problem that I'm having is I think you've conflated the purposes of the research and the background to the research with a risk of the research. So the fact that somebody might suspect something does not mean that there's good evidence or that we know anything about what's best. And in the support study in particular, if anybody said that they knew that there was an increased risk of neurological damage or death at the 85 to 90% oxygen level, somebody might have said that they believed it, but nobody knew that. And in fact, to paraphrase what John Lantos said at the hearing about this study and about this kind of research, when the community as a whole comes out, which they did, and said, we really don't know what's going to happen here, since doctors don't like admitting that they don't know things, you really should believe them when they say that they really don't know. The prospective non-randomized trial from Britain, which seemed to suggest that there would be no risk of death and no increased neurological damage, persuaded at least some institutions, like Children's in Houston, that they should be aiming at the lower level, which they did. So if a children was sick and went to that hospital, if you have born prematurely rather there, they'd have gotten very low oxygen levels between 85 and 89. If they were at Tufts, they would be in the middle, as you described. A lot of places had 85 to 95. Other places were at the very high end. All these different people read the data differently. Did people suspect things? Sure. Does that mean it should be part of the background and the purposes of the research? Sure. But if you're claiming that we knew that there would be an increase in death or neurological damage at the lower end and ROP at the high end, then you knew something that nobody in the neonatal community thought that they knew at the time. And so I would suggest that's a mistake. The suspicion is not knowledge, and it was therefore not a reasonably foreseeable risk. It was part of the background for the purposes of the research.
Yeah, so thank you. So, and also there's been a lot of discussion about the support trial in the literature and at previous conferences as well as at this conference, and it's a bit technical for our more general audience today. But Jerry, if you wouldn't mind just sort of speaking to it generally as opposed to specifically what we should do in circumstances where doctors say we really don't know what to do in this situation, so we'd like to conduct a research on it, and what the appropriate kind of consent in those situations are.
Well, I want to at least briefly get to the specifics of David's. Two things. We never took back our notion, what OHRP said, that the consent form had problems. We eliminated our remedial action against the institution. Okay, that clearly is done. But in terms of saying that consent form was flawed, that was never removed, okay? So that's one point. So in terms of the broader question, absolutely, I was never saying these were proven risks, but the bottom line is you do not just disclose proven risks. The researchers who conducted that trial in numerous publications, both before the start of the trial and during the trial, indicated specific concerns based on physiology and prior data about what they thought might happen at the high end versus what might happen at the low end. We have, in general, always, assuming there is enough support for those sorts of concerns, disclose those to either the subjects of a trial or, in this case, the parents of the subjects, because the bottom line is they are the people or the children who are going to be exposed to those risks. If the bottom line is the only risks you disclose are already proven risks, that's a big problem. You're never going to be disclosing any of the risks that we suspect. So it's a question of how you draw the line as to when a risk reaches the level of being suspected enough. But the bottom line is, sort of a backdrop of a lot of this discussion was building trust. The notion that you're going to take patients and change the care they're given when you're worried about at the high end, and certainly a lot of people were worried about at the high end. There was a question of where you draw the line, when you're going to be increasing the risk of retinopathy of prematurity. Oh, we don't have to tell you that because we haven't proven it. It's the same theme in any study. Of course, you don't limit it to just proven risks. It's research. There are lots of unknowns, and the question is when is something suspected significantly enough that you should warn the person who you're going to expose to that possible risk.
Great, thank you. Sorry, we just have time for one more question because we do want to give the planners a little time to wrap up at the end. But yeah, please.
Sure. So I think each of you talked about ways in which policy, either big P policy or little p policy, is constraining what you're doing. So I'm curious if you could speak a little bit to the political feasibility of lessening some of those constraints. And I know there's a lot of uncertainty around the political environment right now, but can you give us any reason for optimism that some of these policies may change in favor of enabling more learning health system activities?
Is anybody feeling positive?
I don't know about that last caveat, but I think that we have a lot of emerging data that will help inform us in this. Understanding what participants actually want and understanding their beliefs in this and reconciling that with IRB determinations and the regulations, I think are the steps that we're going to need to take in order to get there. I think we have a ton of education to do. And when I say that, I mean that in my environment, with the learning healthcare environment, most public people do not believe they can be in a research study and not have to give you an extra visit, and not have to give you extra blood, not have to do something special for that research study. Yet every single one of those patients didn't do anything special in my situation. So getting people to understand that these sorts of projects are going on in healthcare environments. And in fact, when we poll people, they tell us they expect that these are going to happen in healthcare environments, that we're going to study ourselves and try and get better. But being very explicit about that leads to what we talked about in the last session, which is building that trust with patients so that they can be patients and participants and trust us in both realms. They very much trust us in the medical profession now, at least I think they do as patients, probably too much. They think we know more than we really do. And I think getting them in the equal level with participants will go a long way to helping us in that. So I don't know if I answered your question, but.
I actually just wanted to bring it back to your original question, which is one of the things, it might have sounded like I was complaining about existing policies actually not really helping us get to a learning health system, but actually I think that we underappreciate the value of regulation in this space. Regulation is not only critical for patient safety and protecting patients and human subjects in research, but it's also critical for giving sort of a baseline and actually fostering innovation. Because if we don't have sort of a set of ground rules, it's very hard to operate in these spaces. And I think the challenge we're all facing is that we're trying to really integrate two sets of policies and regulations, one that was designed for research, one that was designed for clinical practice, and that is there's no question that's going to create lots of bumps along the road, and it's going to be difficult. And there were good reasons why we separated those spaces. For ethical reasons, I don't want to go into my doctor's office and feel like he's taking stuff from me just to study me, like in the Moore case or something like that. I want to believe that I'm being treated first and foremost, even if I'm the most willing person on the planet to participate in a research study. So we have to be mindful of this. We all want a learning health system, but we also have to remember why we designed the structures that we designed to try to keep these worlds somewhat separate as we artfully work on ways in partnership with the federal government, in partnership with all the other participants to figure out how to better integrate them. So.
Thank you. And just on a personal note, I wanted to thank everybody that I've gotten the opportunity to work with planning this. This has been really a wonderful experience. But of course, none of this comes together without the right leadership at the top. So to talk about that, I'd like to introduce Dr. Sharon Cardia and Jody Platt. Thank you.
Thank you all for coming. So I'm Sharon Cardia. I'm the Senior Associate Dean for Administration at the School of Public Health. And I'm sorry that Chuck, who's got a terrible upper respiratory illness, isn't able to meet with us today or be here. He's very sad about that, and anybody that knows Chuck knows how enthusiastic he is about the learning health sciences and actually about the ELSI work that his team is doing and that it was represented here. I mean, I think in many ways today's symposium sort of has been a huge testament to the sort of deep dedication that many of the professionals that are sitting here and the community partners have to really serving and protecting the many, many people that our healthcare system touches. And that in many ways we're very, very lucky to be able to even do this work. There are many countries that don't have the kind of infrastructure that we do and have the capacity to do this kind of work to help make a better system, a better medical system, and in my school, a better public health system. We're at a sort of pivotal time where we see the vision of the learning health system, or for instance, a learning public health system, but being able to walk that respectfully out, I'll call it of the idea into the dream, is a major undertaking. So I want to just pull our attention for just a minute to not only the much work that has to be done, but the much work that has been done. I think if you look at the history of the work from sort of the ethical perspective in the biomedical field into this now learning health system, the interdisciplinary work is astounding. I think Chuck's not here, so I'll give him sort of the podium for a minute. I'll sort of channel him that, he actually envisioned the learning health system as a major transdisciplinary enterprise, enough to convince our health system and our medical school to start the very first Department of Learning Health Sciences. And there's a way, that's right. And it sets the tone for actually the seriousness of the enterprise in which we've all been discussing today. I think another great step forward has been this ELSI conference. I mean, this is the first one at the University of Michigan that's taken place that's pulled all these pieces together, and I can absolutely see this being something of an annual event because it's so transdisciplinary. And then I want to pull to one more piece that wasn't really brought out but is actually sort of tucked into the back of the program, is that we have the opportunity to actually produce journal articles for a special edition that sort of set the stage for the whole continuum or spectrum of issues that have been discussed here. And so this is sort of your invitation to submit proposals. I think Jody will also sort of ask you to do so. And then the last thing I'll say, because it's late on a Friday afternoon, is that in no small part we owe Jody Platt a huge thanks. She took the kernel of an idea and walked that dream into reality, and anybody who's put a symposium together knows that's no small feat. And so I'm just going to end there and say thank you so much for a wonderful day, marvelous talks and discussion. Jody?
All right, thank you. Thank you. And I'm going to say that about 6 more times, but not 7, because it's sort of between me and happy hour, which you're all invited to at Hopcat after this, in all seriousness. No, that's not a joke. There we are, conclusion. It's always a little bit interesting trying to put together slides for a conclusion of it for a day that you don't know exactly what's going to be in it, but it has been quite impressive, and again, thank you for coming. Ray at the very beginning said that this was the start of a conversation, and I want to reiterate that and to say that this is actually what I hope is not the start of a free fall, but rather the start of a conversation that's sustainable and will go on perhaps in sort of on an annual basis, on an ongoing basis. I can tell you that in preparing this conference, I spoke with people who are building learning health systems in the state of Michigan, nationally as part of the CORI efforts to build out their network of electronic health records, and others to try to understand what were their questions and what are the actual sort of specific scenarios they need feedback on. We sort of decided it would be an overload to try to bring those in here today, but they're queued up and ready to go, and starting on Monday or maybe after Thanksgiving, please, we'd like you to sort of weigh in on those questions because they are real. And we started today at a very high-level discussion of learning health systems and sort of made our way down to realize that this is real. It's happening at Vanderbilt. It's happening here. It's happening all across the country. And that we are the community of practice that's going to sort of inform the ethical, legal, and social implications of that work. At least that's my hope. Again, we sort of started with this idea that to stretch, to sort of take advantage of the interdisciplinary work that we already know how to do and keep that going. We do have a special issue of the Journal of Learning Health Systems. Chuck Friedman is the editor of that journal, and we're accepting papers for that, and we hope to have a sort of a rich group of papers that will be a part of that. Come again, stay connected, and again, share your thoughts either via email, Facebook. Apparently our Twitter sphere has been very active today, which I'm excited about. And we do have an evaluation in your program. Take a minute, fill it out so we can get funding for another event like this. So, yes. Thank you very much. See you soon.